Welcome to another awesome episode of Mastering Medicare. I am here with my co-host, Alex Mohseni.
Hello.
Hello, Alex. Where are you? Your background's amazing. Anyways, we are here today to record another amazing How Alex Made a Medical Practice. If you have any questions about any of our prior podcasts, please go to our masteringmedicare.net website, and you can see all of the amazing things that we've been doing, as well as the first episode of Alex Makes a Medical Practice.
Which I'm starting to regret now.
Well, listen, it's only been like 2.5 weeks, so like the pain can only just be like surface level.
Yeah,
It can't be so
that's
deep.
exactly right.
No complaints.
Yeah, so
where did we leave off? I mean, we left off with you like got an LLC, you like applied to Medicare, but we have no idea how that actually went. Alex, tell me how applying to Medicare went.
Oh my gosh, I want to pull out my toenails one by one. I mean, it's been so painful.
By the way, we've both pulled out people's toenails. Yeah. That actually kind of thing. It's like jumping on a bag of puppies with like high-heeled shoes. It's horrible. Okay,
yeah,
so right.
So of course I got.
Okay.
So of course I got an email from the Medicare folks a few days later saying that everything I did was wrong, and I have to.
For guidance. Super. Okay, keep going.
Provide all this other information. And so obviously I called them and tried to get clarification, and I'm basically in some I'm in what is it called, in production or in development.
You're in development. But the reason but let's go back for a second. It was that they told you to apply as an individual, even though you want to be a bigger practice. But then they said, no, you can't do that. You actually have to apply as a business.
Yeah.
If you want to, even though you're only an individual.
So it's a whole mess, but I filled out everything they want me to fill out, and so we'll see where that goes. And I've spent the last week or two basically getting my Athena instance, my EMR set up, and the folks at Athena have been really great. But I'm actually, it's complicated. Getting the EMR set up is a lot more work than I thought it would be. And
you're super tech savvy, so that says kind of a lot, actually. If there's somebody who's really tech savvy and they're like, this is a challenge, that speaks volumes to people who may just want to not have to be tech savvy.
Yeah.
That's interesting.
And I guess it's mostly because Athena services so many different types of doctors in so many different types of practices, and they have so many different settings that you have to go through because some doctor at some point requested it,
So you're like sorting through prior pain points for other physicians, even though that is nowhere close to where you are. Okay, that's interesting.
Yeah. And where Athena is kind of lacking, and I'm working with some vendors that interact or interface with Athena, is on the front end in terms of self-scheduling of patients. You can self-schedule as a patient, but as an Athena patient, but you have to log into the Athena portal. And because my focus is Medicare patients, I need a workflow that doesn't require a login. So I'm working with some other vendors to try to get that set up. And then I'm a pure telemedicine practice. So, I want a super clean and streamlined onboarding process. And most of my patients are going to be new. So I want them to fill out some kind of pre-reg forms or registration forms and some basic healthcare information all before their visit. And so that's another thing where it's not really built into Athena for the patient to do that all on their own beforehand. You have to attach one of these other vendors. So I've been talking to those guys to get that all set up, which brings us to today's topic, which is once I started kind of going into like, well, what does a patient need to fill out before their appointment? I realized I don't really know. So, and this is where there's like privacy policies and what are they called? Assignment of benefits and advanced beneficiary notices and all that. And I don't even know which of these apply. And when they do apply, are there standard ones out there? How does one go about getting that done?
Oh my gosh. Okay, so that's actually, it's really important because when you first start a practice, you're saying to yourself, well, they've kind of agreed to have me see them as a doctor. So isn't that like implied consent? So there was a whole thing when I was first starting my practice about when you go into a patient's home, if they let you walk through the door, isn't that implied consent that you are allowed to treat them? So here's how I see the consent process. It's sort of a I love this word, multifactorial type of thing. First, you have to agree that the patient can be treated by you medically. Like you have to agree, I allow Dr. Mohseni to do some following things on me. And you would say, do a video consult, potentially order labs on me, order x-rays. If there was a face-to-face, you would say, allow him to do a certain types of procedures. Some people would even add, order a flu vaccine. Like you can sort of load up the clinical portion of the consent with all the things that you think you might do for somebody. Does that
So
sort of make sense?
is that the consent to treat? Is that what that is?
That's the consent to treat. So like
Okay.
anybody who is taking care of patients should make sure that at bare minimum, whether or not they're, accepting Medicare or accepting any form of insurance, they need to make sure that you are allowed to do it. Just as if you were going to go in for a surgery, the surgeon has to say, explain, I am going to do, I'm going to cut off your left leg and then I'm going to, clean out your right ear. And so you're sort of agreeing to those specific things. But when you're joining a medical practice and this, people are going to be joining you as a patient to your practice, you have to kind of give them an idea of the types of things that you might do. I'm going to do a telemed visit. I will look at your medications. I may speak to some of your loved ones. You kind of want to give a very broad outlook of the types of activities that you might do clinically. Right. So that's like a first, and you can put this all on the same piece of paper, right? But of course, it's not going to be a piece. It's going to be like a scroll through or whatever. But you want to make sure that with a single signature, if you possibly can, with maybe some, initialing of different sections, that you kind of accomplish all of this in one fell swoop. Because the last thing you want to do is go back and forth. Plus, I think in that you have to agree that you want to have them do telemed. I mean, if you were going to do it in person, you might actually want to say in there, because maybe the practice will expand a little bit, and you might say, oh, it would be okay if somebody came to visit me and did look in my ears and did examine me and do a H&P. So I would take a moment to look at other people's consent to treats online to make sure that it's sort of where you've been. And I'm sure that in other telemed experiences you've had, you sort of have seen consents to treat. So you got to get your consent to treat. That's sort of a blanket statement. Then you have to tell them about the following things. You're going to say that you are going to be billing their insurance. And the type of insurance you're going to be billing is Medicare. In some cases, if they do not have secondary insurance, for payments up to 20% of the Medicare allowable cost. You have to tell people that there are certain things that you are going to do that they are going to have to potentially pay for. Now, there's sort of like the general idea that you're going to bill E&M codes, the general E&M codes, like that's implied in some ways. Like I've never seen anybody say that you have to say, for the following codes, you have to sort of say that we are going to be potentially responsible for the other 20%. But there are specific codes that you must do that for, specifically chronic care management codes and the whole family of chronic care management codes. You may want to say and specifically articulate, I bill chronic care management, or I bill certain different chronic care management codes, and you'd have to I have to go back and look up those exact ones. And you actually have to tell them that you may be responsible for cost sharing for this code up to X amount of dollars. Now, I've seen it so that people actually specifically delineate the amount. So like in days past when it was just chronic care management and it was a single 20-minute code, you would say to the patient, you may be responsible for a 20% payment up to $9.49. And every single year you would change that amount. Sure. But in all likelihood, those people are not going to be responsible for it. But Medicare is really funny in that they demand for certain codes that you inform them of the potentiality for cost sharing, which I find to be kind of obnoxious because it turns people off to certain things that you really want them to do because it's good care. Like, somehow you don't tell them they're going to be responsible for 20% off the cost of like an x-ray or another E&M code or whatever it might be. But suddenly for all the good stuff, like maybe I think even RPM, they may have to have informed consent. There's all these different codes that are the ones that make sense to us, to you and me. That's sort of the growing number of codes that are part of that global sort of how to take the best care of patients. You now have to tell them, oh, and by the way, you might be responsible for 20% of the cost of this. And then the person sort of questions whether or not they want to participate in chronic care management, whether they want to participate in these really fruitful code sets that you know is the right thing, which puts you a little bit behind the 8 ball, because now you're suddenly having to say, well, do you have a secondary insurance? Well, yes, sir, I do have a secondary insurance. And you say, well, it's very likely that your secondary insurance will pay. And then they get into this whole thing. Well, what happens if they don't pay? And then you go, well, if they don't pay, this is how much it's going to cost. And then suddenly you're talking about money with the patient, and you're like, it sort of can muddy the waters of just getting them started with what I think would be the good care. But you do have to inform the patient that you will, it's not necessarily an assignment of benefits. Maybe I'm mistaken when I say this, but when I think of assignment of benefits, I think of Part A, which is I am assigning my benefits to hospice, or I'm assigning my benefits to the hospital, or am I assigning my benefits to the nursing home as opposed to, the rehab facility. So that's what I think of when I think of assignment of benefits. But I mean, basically, you have to say that you will bill their insurance company, which in this particular case is Medicare, and that for certain codes, they may be responsible for cost sharing. And then you have to probably tell them that if their insurance company doesn't pay either their Medicare or their secondary insurance, that you will in fact have to balance bill them, because that is otherwise illegal. So you have to kind of talk about, the responsibility for the financial aspects of it, and which is, sometimes you can get as nasty in that consent form as, and if you don't pay me within 60 days, it will be a 20% increase every 30 days thereafter, and, get all yucky. But you can also just say, we will balance bill you. A lot of people do that, and, they balance bill the patient as many times as they can. And then when they don't pay, well, then it is what it is. But I don't think a lot of doctors' practices don't necessarily go after, recoupment in the same way that maybe a hospital might, or a big doctor's practice might. But yeah.
The assignment of benefits, my understanding is that means that instead of the insurance company paying the patient, they're paying the provider, right?
Oh, yeah. So I can see it in both ways. Like the assignment of benefits, I sometimes think of as, well, it's who Part A is going to pay. In that particular case, I'm assigning my benefits to hospice. So in your case, you are assigning the Part B benefits to you for this particular set of services that I guess you are providing. They are allowing you to bill their insurance company.
So how did you get these forms? Is the workflow that you just have to find a healthcare attorney to prepare these for you, or can you get these kind of pre-made ones, or?
There's so many. Like it sounds really terrible, but sometimes imitation is the best form of flattery. And you can just look on pretty much any single doctor's practice, and many of them have their forms that they just download. The American Academy of Family, AAFP, has a bunch of forms that are just like this. I will tell you that as part of when chronic care management rolled out, we did sort of like write the language into our consent forms and did give it to a consultant to make sure it met the language that Medicare was looking for, because we didn't want to be too broad, and we didn't want to be too specific. So when chronic care management came out, we said, please be informed that because you actually have to ask for their permission to participate in chronic care management. And by doing so, they have to basically acknowledge that they are responsible for the other 20%.
Right.
Because otherwise you can't, it was such a pain in the double ASS. I mean, it was not easy to sort of stop people in their tracks. They're like, sure, signs. Oh, wait, what is this? Like, suddenly you're asking me to participate in chronic care management. Why am I not automatically enrolled? If your practice does chronic care management, meaning they bill Medicare for, certain services that they provide in order to provide, good care for you, why do you have to agree to that? Because you're going to do that same crap anyway.
Right.
So, it's certainly something to think about. I don't know what's happening with the emergency, whether or not you have to still go through this mishigas, but like, it certainly seems to me that if you have some language that you're not totally sure about, it's always worth it to ask an attorney. And as we always go back is, thank God we're not lawyers.
Yeah.
So yeah, but I would say, imitation is a very nice form of flattery, and you can certainly look at a lot of doctors' practices to see how they've done it in the past. And you can refer, and by the way, that sort of brings me to the next thing is you can refer to your HIPAA compliance or any FAQs in that document and then refer them to your website. They don't necessarily have to sign the HIPAA acknowledgement. At least that was never how I did it. It was just that they acknowledged that they could find it on the website. It
So
did,
that's smart.
yeah, they can go look at it if they want it.
Right.
I have had in doctor offices where I do have to sign their HIPAA information, but then they let you take those documents with you. So it seems like you just have to acknowledge that you have had access to them.
Right.
The tiny little, 4-point font, that little thing.
Yeah. But I'm glad you mentioned the American Academy of Family Practice. So are you a member of AAFP?
I am not, but they have a lot of great free resources. I mean, through the American Academy of Home Care Medicine, there were some resources. There was some mind share there, but I think that the AAFP has been a real resource for just a lot of doctors, no matter what their specialty is.
Yeah. Cool. Okay. That is awesome. So I want to share this story. So, it took me about 2 or 3 weeks to get set up on Athena. And so I called my dad and I said, can we do it like a test encounter? I want to register,
Yeah.
And just like every other EMR I've ever interacted with, you go through all the training and then all of a sudden you're all alone trying to do it yourself. And I had no idea. I was so frustrated. And it's not the Athena folks' fault. It's like when it's a totally new interface, like I did not know how to add a patient. I couldn't get him registered. Even once I got him registered, I had no idea how to start the clinical encounter and start documenting. And it just shows you that even when you choose an EMR that is head and shoulders better than what we experience in the hospital environment, there's still a lot left to be desired. And during this time, I thought to myself, why can nothing be as simple as paper? On paper, it is so obvious what you have to do. The workflow is self-evident. It requires zero frustration. So this is where, remember, if you look back at kind of iPhone design over the years, earlier there was what they call the skeuomorphic design, which I think it means like it replicates or reflects the physical world. Like the address book actually looks like a book. You know what I'm saying?
Oh, right. So it uses cognitive cueing in a way that's really, yeah.
Right. And so although it might look kind of dorky or whatever, if somebody created
iconographic thinking, yeah.
If somebody created an EMR that truly kind of reflected what we're used to doing on paper, that's probably the best way of doing this. And anything outside of that is just why? Why?
Yeah. Well, we've all used different things. Like, I don't know, we used T-sheets for a while, which, hats off to some guys at Suburban Hospital for inventing that one. I don't remember.
Really?
It was like, yeah.
I didn't know that.
I don't know if the whole T-sheets, but like they had used it. There was a special thing that we used that was like T-sheets, but then used like a funky pen and then it pushed it up. It was just so easy, which brings me to the idea, like we are so stuck in this idea that, there has to be choice. Sometimes less choice is better. Imagine, or like, here is it's like a digital EMR in a box, and it only does two things. You can either do it this way or you can do it that way. And then just sometimes choice makes things really emotionally very difficult because you're like, well, wait, I have to choose. I have so many choices to make about like what things I want up here and what things I want down here and how do I want the template to look. I mean, sometimes you're just like, give me the template. I will just follow whatever rules you set out for me. I mean, I think that choice is not always so great. The other thing that you and I have talked about, which, I mean, if anyone from Medicare ever listened to this, I would be like so delighted. But the idea that if you're going to do a telemed visit, why can the telemed visit not just be the documentation for that visit? And you could just go from visit to visit to visit, and you don't have to document anything because you pretty much, it's all there. Here's
as
your
long
physical
as you
exam.
record it.
as long as it's recorded, it should just be the representation of that visit. And I think for a while there, I was using Dr. Chrono, and I think they had kind of like had that in mind with Google Glass, and like they had integrated with Google Glass so that you had like little camera here. And I think that a lot of doctors were trying to do that. They were trying to record it, but I think the idea send it up to a scribe who would then turn that video visit into sort of a 95, 97 EMR, like documentation E&M visit. But it would be kind of great is if there was some sort of movement away from the written documentation that just took a video visit and just, whether it's in person or on the computer, and just said, boom, here it is. I mean, that would be kind of cool. Can Athena listen to your visit and fill in the critical elements of like 95 or 97 documentation? Do you think it could do that? If you list, like if you queue it and say physical exam, regular physical exam or something like that, except blah, 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 could it automatically put that stuff in there?
There's stuff like that. I mean, even the clunky hospital EMRs allow some variation of that with Epic and Meditech and stuff. But you know what I really wish? I really wish that somebody created a way for me to document on paper, because I could document an entire encounter in under 60 seconds on paper. And then let me just
like check boxes.
Yeah, check. And then, all I need is like 3 sentences.
And then turn it into actual words.
Yeah, and then turn it into what the EMR needs in order to do its billing and all that crap, right? But take me away from the clicking. It's not the clicking that's the problem. It's the like, oh my gosh, where do I document this? Where do I write this? Am I doing this the fastest way? I'm constantly asking myself, am I really doing this the best way? The only way I know how is I got to click through these 4 things and scroll all the way down. That's how I started. And I got to remember now, right? The cognitive load of trying to remember, how do I do this? I never have to think about that on paper.
So it would be interesting to say that you have learned helplessness then, that there's a certain amount of clicking. And Alex, this is a perfect thing for you. Put something on your screen that says, remember when something is inefficient, because we do get used to these massively inefficient systems and just work around it cognitively. We cognitively work around and be like, well, it took 21 clicks to do that. Oh, well. And then we just sort of learn to accept that as the norm because we're just creatures and we just realize we have no power. So it would be interesting in the process of this, as you are sort of a systems and efficiency buff, to remember if something is really hard to kind of have at it and say, why did that take so long? Is there a way to make that one? Is there a way to save a second here? Or was there a way to save 2 seconds? Because each of those seconds, we all know, is like a tremendous amount of cognitive processing, even though it only is a second of time. So yeah, interesting. Well, you'll have to see how that goes. I mean, what I find interesting is that there is still no and this is of course I think where we're headed with this, start a telemed practice in a box, that nobody has said to themselves, wow, let's take a easily accessible commercial grade EMR and make it really easy for a doctor to just completely convert to telemed. But I guess maybe that will come over time because a lot has happened in the past 8 weeks, right? People have pivoted in ways they didn't anticipate and have had to adjust. And I'm sure the EMR's development teams have not necessarily caught up to it. It's been a lot of workarounds.
Yeah.
Do you feel that? Do you feel that?
Yeah, totally. Yeah, and in fact, I've had several doctors come to me, and I just spoke to several of them over the last week or so, saying that, hey, listen, I have my brick and mortar job or whatever, but I want to create my own solo telemedicine practice. I don't want to work for, one of the big $4 billion companies on telemedicine. I want my own practice because I know how to acquire some patients here myself. But I want it to be completely streamlined. I don't want to have to pay for a bunch of office staff and all that. So I actually had a wonderful discussion with a nephrologist who's trying to do that, and he chose completely different EMR and setup from me. So he and I are going to keep in touch because I'm really curious. What's his experience in terms of trying to create a single doc, pure telemedicine practice with 0 office staff. And in fact, another idea came out of that, which is, what if we created a little like consortium of solo telemedicine practitioners? Because he told me, he's like, hey, listen, if I have an urgent care case, I'm happy to send that to you. And if you have a nephrology case, send it to me,
Oh,
So we
yeah.
could create our
Yes, I
own
love it.
little,
Mayo
our own,
Clinic.
that's right, our own little network of solo telemedicine doctors with their, and so anyways, so some new things are starting to kind of formulate in my head. And it'd be awesome to be able to support the ability of doctors to do that.
Well, I think that's really cool. So basically, what we're telling the audience right now is if you are thinking of starting a solo telemedicine practice, join the Mastering Medicare, join the Mastering Medicare Consortium. That would be
Yeah.
very cool. Yeah,
Yep.
absolutely. And I think, can you imagine? It's like a subspecialty group. Oh, we've got a guy, we've got a guy, we've got a guy, we've got a
Yeah.
guy.
Yeah.
I like it. I
Yeah.
like it. Oh, there's never an end. There's never an end.
Yeah.
Love it. All right. So wait, so we got you through. You've got your Medicare is in development. You've got your telemed product has been selected, I guess, through Athena. You've decided, or you haven't. Okay.
I'm still testing. I'm playing
Okay.
around
Still
with
testing. I love it. I love it.
I'm
But you
playing around
got
with
Athena.
Doxy. I've got
Oh, Doxy.
Athena.
Okay. Yeah.
So there's, I guess, three pieces that are not totally set yet for me. One is self-scheduling of appointments, because I don't like or want the Athena module. One of the key things that's missing from Athena, the scheduling piece, is like, I want the schedule in my scheduling system to look at my Google Calendar and say, wait a second, Alex is already blocked off from 12 to 2 and the appointments there. I have to I don't want to manually go in and do that, because I do a lot of stuff other than this, right? So it's not like I'm just a doctor from 9 to 5. So one piece that's still to be figured out is self-scheduling. I'm playing around with a tool called Cogsworth, which has a HIPAA compliant self-scheduling, which I really, really like, but it's still missing a few things. The second is going through all the registration, the kind of pre-visit paperwork, and maybe even getting some of the pre-visit clinical information. What's your chief complaint, medications, allergies, all that garbage. Like, I'd love to get that done before the visit and in a self-service way. And the third is the actual video, like HIPAA compliant video piece. So those are the three elements that I'm trying to figure out. There's some solutions that claim they do it all. I just talked to one of them. They're okay. So anyways, that's what I'm still trying to figure out.
So what's gonna be happening, would you say, in the next week when we tune in next week to see the Alex Makes a Practice update? Yeah. Where do you want to be in a week?
In a week, I want to have had at least, let's say, 3 to 5 telemedicine encounters with whatever system I put together, so that I can kind of just, talk about how it went.
Oh my God, that's so awesome. So if somebody wants to refer a patient to you because they listened to it today, but in general, how could you get a referral from somebody who's a listener? Because you're going to be taking care of people. Just right now, we're focusing on DC metro area. That's pretty much it.
Well, so a funny thing has happened. So I'm already getting some referrals for cash patients in other states, which
nice.
I'm licensed in most states. But if you have Medicare, then I'm limited right now to kind of Maryland, DC, and the website is canarydoc.com, canarydoc.com.
Oh, I love it. Okay, so next week, the update, so you can get your 3 to 5 patients. I'm so excited for you. Okay, fine. We'll hear about the disasters next week. All right. Yeah. So signing off again. This is Mastering Medicare. You can reach us at masteringmedicare.net. We are an amazingly fun group of people / me and Alex who are going through Medicare little by little and watching Alex make a practice and learning about all the other parts of Medicare and how senior serving professionals and how even just adult caregivers of aging parents or anybody who wants to learn more about Medicare. So signing off. See you next week. Ciao, Bella. Bye.